Welcome to the Emerging Scholar Podcast, Season 1. We hope you enjoy this series of great conversations with leading medical researchers that's designed for graduate students, medical trainees, residents, and fellows to help you on your journey towards your first scientific project. Welcome, everyone, to Episode 10 of the Emerging Scholar Podcast. We're back with Dr. Robert Platt for Part 2 of our interview, where we're focusing on causal inference in epidemiology. Dr. Platt and I will talk about different approaches to inferring causality, do a deeper dive on some of the assumptions that we need to make when making causal inference, and try to apply this as it pertains to one or two papers that Dr. Platt has published recently. I hope that you really enjoyed Part 1, and Part 2 will give you a little deeper dive into this area, and hopefully this can inform the questions that you're asking and inspire you to try to take on a causal question or use causal methods to try to answer a really important clinical question that you have. All right. Welcome back to the Emerging Scholar Podcast. My name is John McGavick. I'm the host, and it's my pleasure today to be back again with Dr. Robert Platt from McGill University. Welcome back, Robert.
Thank you. Thanks for having me.
So a couple of weeks ago, we talked about the intro to causal inference. We talked a little bit about how you would set up your research design if you're working with a large administrative data set. We talked about the three core assumptions for causal inference: exchangeability, consistency, and positivity. So now imagine we're working with a resident. We've got our data set. I think we used gestational diabetes as an example before, but you've published some recent papers too, so maybe you can use those as an example. Where would we go next in terms of starting to work with our data set to design that experiment? Would we start thinking about the assumptions and how we would address those? Or typically, what do you do when you're working with a grad student on a causal question?
The first step I would think about is establishing really what's the question we want to answer. And I'm going to work with an example from my recent work with what's now a former grad student of mine who's now on faculty in Toronto, Sonia Grandi, where we wanted to look at levothyroxine treatment for subclinical hypothyroidism in pregnancy. The first question is really, what do we mean by that question? We want to look at people who started levothyroxine during pregnancy after they got a diagnosis versus people who didn't start after a similar diagnosis. And that sort of starts to frame us into the idea of, and we talked about this last time, trial. And the idea is, if we had unlimited resources and if we really wanted to know about this question, we could enroll pregnant people who have a subclinical hypothyroidism diagnosis and randomize them to levothyroxine versus not. And we would follow them and go from there. Once we've got to that point, and given that we can't do that trial, the next step, and at least what we did in this paper, and we took a very target trial emulation approach to this paper, the next step would be to say, okay, let's now really get into the weeds about what the trial we would have wanted to do would have looked like. Following on the work that Miguel Hernan and his colleagues have done, they proposed lining up a table where you have all of the standard features of a trial, and then what you would do with your trial, and then what you need to do in an observational study in order to mimic that trial. So eligibility criteria. We want women who were diagnosed with subclinical hypothyroidism who didn't have previous thyroid disease because they probably were being treated or they were at risk for being treated prior to pregnancy. And again, if we were randomizing them, we would have randomized them to levothyroxine or a placebo. In the observational data, we can think about setting up those exact same exclusion-inclusion criteria and build a cohort of women or pregnant people with new onset subclinical type hypothyroidism. And we can start looking at, okay, who are the people who initiated levothyroxine and who are the people who didn't? So we're starting to start with that raw administrative data, which is just lists of things that happened during the pregnancy, and starting to build it to look like it might look like the trial that we wanted to have done. They're really the key point and the key challenge here, and with this particular problem, is there's a window during pregnancy in which you can be diagnosed with subclinical hypothyroidism, and there's a window after that in which you could start taking levo or not. So there's a lot of potential problems with immortal time bias in a study like this one, because it's easy to get those times misaligned and end up with some problems. So just getting down to that, okay, here's our initial cohort of eligible people, and here are the people who started, here are the people who we could look at who didn't start. That's the first step in getting to this target trial emulation process, I guess I would say. And then we can go on from there. Maybe I'll stop there, and if you want to jump in with anything.
No, that's great. So what I do like, and we'll put a link to this paper in the show notes, but Table 1 outlines what the trial would actually look like, and then you describe how you're going to design that within the administrative data set. And my understanding of the target trial emulation, the first part that's probably the key difference between what we would typically do, which is say, let's compare everyone that received the drug to everyone that didn't, and just do a survival curve or a hazards ratio, whatever, is that you have very strict eligibility criteria. And I want to ask a little more about immortal time bias and how you address that in the design. But if you just compare people who received the med versus people that didn't, you have high risk of confounding by indication as well. So using this target trial emulation approach, rather than just including everyone, you have really strict inclusion criteria that ensure that you're approximating almost exactly what you would get if you actually did the randomized control trial. And one thing that I liked about what Hernan says, he says this isn't going to replace the randomized control trial. This is just another body of evidence that will either inform the future randomized control trial or could be added to the existing literature, right? We're not saying that randomized control trials are done. We're just saying let's do a better job of working with the administrative data that we have, right?
I think I'm going to jump around with the things that you were discussing there. The last point you raised is very important, that this is, and Miguel is really good about when he talks about this, always saying, if we had unlimited time and resources and we wanted to answer this question, of course we'd want to do a trial.
Yeah.
But we don't have unlimited time, we don't have unlimited resources, and we have available observational data. So what's the best thing we can do with that observational data? It's not going to, like you said, replace the trial, but it provides the evidence that we can.
Perfect. So then my first question, then, because I asked a lot in there, sorry, would be like, how is this different from just a regular, like if we were just going to compare women during their pregnancy who got levo versus women that didn't, right? That would kind of be a standard approach, right? How is this different?
So in my mind, the most important difference is the immortal time bias that you and I both mentioned, that one of the outcomes that we'll get to in a second, miscarriage or spontaneous abortion prior to 24 weeks gestation. If you just look at women who got levo versus women who didn't get levo, the spontaneous abortions are going to be more likely to be assigned to the non-levo group because you can get levo anywhere during your pregnancy. You can get it into the third trimester. So your pregnancy has to survive long enough to get levothyroxine in order to be put into the exposed group. What the target trial approach would do is say, okay, that pregnancy where the woman got levo in week 34, the target trial there is randomizing people at week 34 to levo versus not. There's a subtlety in this design, in this particular case, that in fact, we call this a target trial. It's more like a bunch of little target trials. That is, what would happen if you randomized women at 20 weeks to levo versus not, and then at 21 weeks to levo versus not, and so on and so on and so on. And that gets around this immortal time problem. There's a paper that Miguel and I and some colleagues wrote about immortal time bias and target trial emulation in, I think, Journal of Clinical Epidemiology, that talks a little bit about this, about how important it is to the key elements of time zero in your study. And just looking at sort of ever exposed during pregnancy versus never exposed during pregnancy really creates that potential problem of the longer your pregnancy goes, the more likely you are to be exposed, which kind of gets this reverse association.
So
sorry, you go ahead.
So the problem there is that if you use traditional approaches, people are entering the cohort at different times, and there isn't like a clean start point like you would have for a trial, right? You've been randomized, you meet inclusion criteria, you're randomized, bam, zero. Time zero starts now, then we give you a medication.
Exactly.
So where does immortal time bias come in? If we don't all start at the same time, can you give me an example in this study where things could go awry?
Let me think about that a little bit. I guess
There'd be a misclassification.
A misclassification of person time, which, and I should point out that another way around immortal time bias that I think is a reasonable thing to consider in this scenario as well. A Cox model, say with time varying exposure, where as long as you're allocating the exposure to the right thing, then that's okay. And so a person who is not exposed to levo and has a miscarriage at 19 weeks, those first 19 weeks are assigned to non-treatment. And then if you have another person who is unexposed up to 22 weeks and then gets levo and then is followed, you assign their person time accordingly. You give those first 22 weeks to the unexposed group and after 22 to the exposed group. And that's a very reasonable way to approach this kind of problem as well, that gets around the challenge that we're talking about.
Okay. And so in this study, how did you define cohort entry to avoid a mortal time bias?
So we did two things. One is defining eligibility. And again, this is thinking about it as a trial, as the diagnosis. And if you're going back to actually doing this as a trial, you would be recruiting at the time of diagnosis and then randomizing to treatment versus not.
Right.
And that's in effect what we've been trying to do with this, is to set up the cohort as if we had enrolled them at the time of diagnosis, irrespective of treatment. And so everybody has a fair shot of getting enrolled at the same time. And then everybody starts either their active treatment or their control again at the same time. Yeah, and that basically means everybody has the same chance to be followed up for the same amount of time. And if we had, and again, I should give you for the show notes the other paper I'm referring to. If we had a whiteboard here, I would be drawing all kinds of line diagrams on the screen for us, just to say, and that's the easiest way to represent it. Sort of, you say the start of pregnancy is time 0, and then you draw a line, and then the person has a diagnosis, and then you change the color of the line, and you kind of want those lines to match up in the exposed versus unexposed groups. And in this paper by Hernan and colleagues, we did a lot of that just in terms of helping those time windows line up, because that's essentially what you want. You want to make sure that exposed time is assigned to exposed people and unexposed time is assigned to unexposed. So the person who is treated relatively late in pregnancy, you want to make sure that the early part of pregnancy is assigned to non-exposure, because otherwise you've made them immortal for that time period, basically.
Okay. That's clear, and we will link that in there. And I'm also a visual learner, so it's tough on a podcast to describe that. So now, in a randomized trial, you would have women who are pregnant, they're diagnosed with subclinical hypothyroidism, then we would randomize them, right, levo or not. Now, you, in your administrative data set, you have your inclusion criteria, so that's clean, just like a randomized controlled trial would be. You've created your cohort entry starting point so that that's balanced between the two groups. Now, exchangeability would be, the randomization part is where that addresses exchangeability, right? Like no unmeasured confounding is the beauty of randomization as an instrument. Now, in this case, you talk about how you try to address exchangeability, I think, through inverse variance weighted treatment weights, right? So you would take a set of variables, descriptive variables between the exposed and unexposed, right? And create this inverse probability of treatment weights, and then you would match individuals based on those.
Yeah, or you would do one of two things. And actually, I'm gonna change things slightly here. We actually used propensity score matching in this case,
okay,
rather than inverse probability weights, and those two are philosophically similar but philosophically different. Their approaches using the same tool. One of the things that we did, and I mean, the exchangeability assumption you're trying to make always is the no unmeasured confounding assumption, which translates in practice to, hypothetically, if we look conditioning on all of these things that we think might have been confounders, it's as if people were randomized to treatment or control within levels of those things. So we're building this set of variables saying, oh, these are all the things that might affect both treatment and control. And I think we talked about, and I know you talked on another podcast about DAGs, basically saying, if we had a giant DAG that said, these are all the things we think could have affected both, we'll control for them through any number of ways, but we in this case use propensity scores, then you are at this point hoping that exchangeability holds or assuming that exchangeability holds after that point. The one interesting thing about this paper from that perspective, that's a bit of a diversion, but worth mentioning, is we used an algorithm called the high dimensional propensity score here, which is essentially just saying, let's build a gigantic list of potential confounders and build the propensity score based on that gigantic list, and then match on that high dimensional propensity score. And that's a method that takes a fair amount of computing work, but it's relatively straightforward when you look at it. It's a complicated process, but a straightforward algorithm. You just do these 7 steps. Mm-hmm. And then it's been shown, at least empirically, to do a reasonable job in a lot of cases of controlling for confounding in these kinds of settings. So what we've done is build this propensity score, find all of our exposed people, and then say, so for a pregnant person exposed to levo at 33 weeks, we looked in this case 4 others who had not yet been initiators at that week, so they hadn't started at that week, and they had a propensity score that was close enough to the treated person. And then that gives you a little tiny kind of micro trial there, or a micro emulated trial.
Yeah, so looking at table 2, and we did something similar with a natural experiment we did on cycling trails, actually, which I'll try to ask you a few questions about. You just report the standardized difference between the treated and the untreated. And you had said this, but when we read the papers, you did 4-to-1, because in the administrative data set, right, you don't have as many exposed women, so not as many women are being treated for whatever reason. But once a woman receives a diagnosis, there are going to be, I guess in your case, a number of women that were untreated that you could match using the propensity score approach, which... You had 33 variables in there, so this must have been a pretty robust data set, which in our administrative data work, you don't often have all of those variables in there, which was really strong, right? Like you had pre-specified based on your DAG, right? Gestational age, trimester of trial entry, gestational diabetes, BMI as a category, smoking, like a lot of behavioral things that aren't typically in this, right? Based on that, you match 1 to 4 because you have a large enough data set where you can have 4 controls for every 1 treated, which juices up your power a little bit. And then when you look at table 2, because you've matched them on this score, you can see that it's almost like you've got a randomized controlled trial, right? There's for a lot of these, I've never seen standardized differences this small, actually. So the matching must have worked really well. So you've essentially set up this really nice emulated trial in this data set.
The only thing I'll point out there is that the matching and the standardized differences look like they work only with regard to what's in the data set. I mean, we're assuming that there's the variables that we've captured cover the key confounders. And of course, that's an unknowable assumption, but it's nice. It is reassuring at this point to see that the standardized differences look as good as they do.
But the unmeasured, we don't. A propensity score match does not control for unmeasured confounding.
Exactly.
So that's a caveat there. And then you describe an intention to treat approach, right? So you would, you've defined your outcome, right? So the outcome in the trial is going to be exactly the same as the outcome in your administrative data set. So in this case, it was mortality.
Yeah, the stillbirth or spontaneous abortion or early pregnancy loss.
Which is in an epidemiological context, it's clean outcome, somewhat easy as long as you've got data from a national statistics data set, right, or vital statistics. You'll be able to fairly easily ascertain that outcome, right?
Exactly. Exactly. We were working with a really pretty high quality, relatively nationally representative electronic health record data set from the UK. So it has a lot of information. As you pointed out, a lot of the lifestyle factors that are not available in, say, administrative claims databases in Canada are available in this data set, and mainly primary care driven these data, but most care gets brought back to the primary care provider and entered into the EHR. So you can be fairly confident that pregnancies in particular are well recorded, but then serious problems are still also well recorded. Plus it's linked to death data and so on. So like you said, it's a pretty robust data set.
So in a randomized controlled trial, we would bring all the women back for a follow-up, or, they're in hospital, let's say, right? So we would be able to ascertain the outcome and apply an intention to treat. So for whatever reason, if a cohort of women moved out of the UK, or they moved providers, or they, for whatever reason, going to their care provider and decided to go somewhere else, whether they had their pregnancy at home, and for some reason we couldn't ascertain it, right? Whatever arm they were assigned to at the beginning, you would treat it as if that's what they received. So in this case, you had the same intention to treat analysis, and you tried to handle missing data in a certain way. But is the intention to treat in an administrative data model the same as you would do for a randomized controlled trial?
There's some debate about that. Some authors who've written a lot about this target trial approach say it's not really the same intent to treat and intent to treat, but this gets into a longer discussion about what's the trial that we want to emulate, in particular with regard to what the treatment comparisons are. So this might be better worded when we say intent to treat. It's studying treatment initiation versus not initiation. And so you're essentially saying they might have started and stopped after a week, but they might have started and continued on. We could have looked at sustained treatment after initiation, and that gets it to more complicated time varying treatment strategies questions that I guess I would say are this time conceptually relatively more complicated to set up, because you have to start thinking about, okay, what does it mean to start levothyroxine and stay on levothyroxine? You get into thinking about a so-called per protocol approach.
Yeah.
You've got to think through really what that protocol would have been before you assign that. So yes, we took kind of the simple way out here.
Well, yeah, the randomized trial approach, right? So in your case, they're not randomized, but they were prescribed levo, right? And then no matter what happened after that, they remain in that arm, even though you may have data to suggest that maybe they stopped taking it. Or so, yeah, beautiful example. So this would be a target trial emulation approach. Like you said at the beginning, decently powered trial, 821. But I guess from a physiological statistics standpoint, there were only 57 endpoints that you had to work with, right? So it was a little challenging in the end to come up with a precise estimate. But this is a beautiful example of how you would. And pharmacoepi is really nice in the sense that in terms of addressing some of our assumptions of causal inference, right? Your intervention is consistent, right? It's clean. It's fairly clean. You've got a good clean exposure that you can capture. For some of the other ones, although I guess in your control arm, when you don't receive it, is that a bit of a messy control arm because you could be getting a little bit of anything?
Yes, I think that's a good point, a good question. Yes, that in a real trial, you'd either be comparing to placebo or placebo plus usual care,
right?
But you'd likely have something written down about what constitutes usual care, and you probably would want to give some consideration. Again, this is kind of the simple way to approach it with this initiation approach, because you kind of say in both arms, we don't care what happens to you after day 0. So it becomes very pragmatic in that sense, like a pragmatic trial. Whereas in a more controlled trial, you'd want to say, okay, these are the ranges of things that constitute usual care. These are the range of things that constitute a protocol violation, et cetera. So you could think that through in a more per protocol design. I want to come back to sample size for a second. You're right. The disappointing part of this study, I mean, was the sample size. We started with 20 odd thousand pregnancies, and I'm trying to find the flow diagram. There it is. We ended up with on the order of 5,000 pregnancies that were eligible, or 6,000 pregnancies that were eligible, that sort of meet our initial entry criteria. The problem is then when we got down to the exposed, we really didn't have that many. And then the good problem is the outcome is relatively rare. So that ends up shrinking the trial down to something that, I think in our abstract, we concluded we were unable to definitively rule in or rule out associations because the confidence intervals were quite wide. But what this exercise showed us was you may have a big observational data set, but when you really dig down and say, okay, who are the people I really want to compare to which people, you might end up saying, okay, There are lots of pregnancies in this cohort who are just not relevant to the question that we're asking. And going back to the first question you asked at the beginning of if we just looked at users versus non-users, we would have considered all of those not relevant pregnancies in our study, and we probably didn't want to do that. So these are trade-offs we make with this kind of design.
Yeah, so you could use the entire sample and have a lot of power and come up with the wrong answer.
That is, yes,
So,
that is unfortunately quite possible. Yeah.
right. If you want to chase p-values, you can go for that, but your answer will be wrong. Whereas if you take the time and think about it and use this emulation approach, you'll get a much better answer. Unfortunately, the risk of maybe having limited statistical power, but it's closer to what you would actually see in a randomized control trial, which is where we want to go anyways.
Exactly.
Lots of power is not beneficial if you're going to get the wrong answer. So that's a great example of how to use the target trial emulation model. I think we'll link to that. We'll link to a couple other ones. I guess places where you would use this, a famous paper from the Hernan group, they compared the Moderna vaccine to the Pfizer vaccine, right? You can use this in areas where like you're never going to get the head-to-head comparison, right? So let's try it. Any other good places for a target trial to start?
I think the vaccines, the COVID vaccines is a great example and another illustration of some of the challenges we saw in this paper, because you're looking for, again, those people who would have been potentially exposed to both vaccines. And it's not always clear that people were, in Canada, we had certain vaccines at certain time windows. It's hard to find those people who at the same level of virus transmission were eligible to get two different vaccines. It gets really quite tricky, but I think it's the best way, like you were saying, to get fast answers to these questions. And like you said, we're never going to get head-to-head trials of Moderna versus Pfizer. We have to resort to observational data to find those answers.
Yeah. And so the first author on that was Barbara Dickerman from the Causal lab. So in addition to target trial emulation, the other one we kind of touched on last time, and I'm a big fan of right now, is the application of natural experiments, or we use sort of a difference in differences approach where you have, let's say, a big change in policy. In the U.S., this happens a lot, like the Affordable Care Act comes in. In our case, we're really interested in changes to the built environment where on an observational standpoint, you could compare neighborhoods that have this infrastructure or states or provinces that have this policy compared to ones that don't. But if you take a step back and say, well, these interventions or these experiments started at a certain time point, if we have the administrative data, why don't we treat it like it was not a randomized control trial, but a really big intervention that came in, and then let's do a natural experiment and see whether or not there's a causal effect there. I'm really keen on that. Like, what are your thoughts on that, and what are some of the caveats for doing that? And let's say it's a new drug comes to market, for example, or in one of our students' work right now, we're looking at changes in screening practices for gestational diabetes, where the criteria for what constitutes gestational diabetes and potentially the people being screened has widened, right? And then what's the effect of that on whatever outcome?
I think it's an important set of tools that are probably underutilized in the health research space in general, and in epidemiology in particular. I have a daughter who's doing an undergrad degree in economics, so I get a lot of exposure to natural experiments through conversations with her. And it's very popular in the econ literature to say, let's look for natural experiments or external insults to a system that suddenly change a system, and then you can exploit that sudden change to see if the consequence of that change has a causal effect on exposure, on some outcome. So you gave a good example of policy towards screening for gestational diabetes changes suddenly, and then you can look sort of immediately before the policy and immediately after the policy at the people who would have been affected by that change in policy and see if the screening does anything, because it's as if those people kind of were randomized. If the policy changed on January 1st, then someone who was treated on the 31st and someone who's treated on the 2nd, it's more or less random that they happen to get those dates. And so that can be a very, very powerful tool. And we've done work looking at this with policies around coverage of pregnancy-related outcomes or events, and exploiting differences in policy across states in the US and changes over time within states. So if two states are side by side geographically and have relatively similar demographic characteristics, and one changes policy and the other doesn't, then you have this kind of before after two groups that, under the right set of assumptions, is a very powerful tool to say, yeah, we can infer that there's a causal effect of whatever that policy was meant to affect on outcomes. And it's a very nice, I think it's probably should be thought of as a very nice complement to what we typically do in epidemiology. I think of it as a trade-off of, with a natural experiment, you're looking for that external insult that creates this randomness. With our typical study, you're looking for control variables, confounders, that if we balance the confounders, we can hope that it's as if people were randomized. And those are based on two different sets of assumptions, two different sets of choices. And I think we could learn a lot from the cases where we really don't think we can control for confounding very well using our methods. Then we should look at, is there a natural experiment that we could do? And B, if we can do both sets of studies, are the answers consistent with each other? Do we get the same conclusion, or at least consistent conclusions between the two?
And like you said, this is big in the econ area. We did an interview early with Bapu Jena, who hosted a podcast called Freakonomics MD. His whole lab was designed around natural experiments. And when they were coming up with really unique questions and debating them at the beginning of the week, that was their question. Like, can we actually test this with a natural experiment? You're a cyclist and a runner. Like, one of his really interesting questions was, when you shut down roads around a hospital for a 5K road race or for a marathon, what happens to people who have a cardiovascular incident and have to take an ambulance into the hospital, right? Does that change in traffic actually influence it? So you have this nice natural experiment where you have marathons happening throughout the country. They're somewhat random in terms of where they are. And then I guess the key there is you do need the counterfactual. You have to estimate some way of saying, if this marathon didn't happen, what's the trajectory, right? And so that's the key element there, I think, is saying, like for us working on cycling infrastructure, they built this bike lane. There's no way we're ever going to randomize people to a cycling lane or not in their neighborhood. But can we estimate the counterfactual in a neighborhood that didn't get one but looks like and can almost replace the neighborhood that did? And then we can track the outcomes in that control area and then get a nice estimate of that counterfactual.
I think that's a great example of what you're looking for. Again, you're looking for a policy change or something external, and ideally a comparator or a counterfactual in which the policy change didn't happen that's close enough. There was a series on Twitter or X the other day that reminded me of a commentary I wrote with a former student during the COVID pandemic, where we basically cautioned against using the COVID pandemic as an instrument because the ideal natural experiment is an insult to the system that changes one thing, right? That is very direct in terms of what it does. Whereas the COVID pandemic changed everything. It went from school closings to shutdowns of retail to shutdowns of restaurants to being less traffic on the road to the mental health consequences of all of us being alone in our houses and so on and so on and so on. It was just too broad of an insult to the system to be used reasonably as a natural experiment. So thinking about where you can pull those out, it's the kind of thing, and you talked about Bapu Jena, listening to people who do this a lot, and it's typically, again, economists, think about, okay, where could we find this external source of variation that drives a natural experiment? It's really illuminating for people who don't use those methods a lot. So I'd recommend that we in health research and epidemiology in particular think more about this kind of stuff, because it is just a very useful component of the toolkit that we can use. And I think that there are sort of loose philosophical links between the target trial approach and the natural experiment, because you're always trying to think about what you described. Here's a situation where something happened, and here's my best representation of the counterfactual of what would have happened to that person in the absence of the exposure. And if we just press on thinking that way, I think we get a long way in terms of doing better research. And ideally, it sometimes will include target trials, sometimes it'll include natural experiments, and sometimes it'll include something else, whatever the best tool is for the job that we're doing.
Yeah. Is it fair to say that the assumptions for causal inference still play in there? So I think you just talked about COVID as a bad one. So would that fall under the consistency assumption that there are too many interventions when you say COVID, right? It's too complex of a policy. It's not a policy, but within COVID, you could say masking, for example. But even masking might be a clean one if you had a good example where you knew masking was either mandated or well adhered to or, fully embraced, let's say, and it was a clean intervention compared to an area where you knew that no one was masking. And then same thing, you'd want to design your national experiment to whatever way possible address those assumptions of consistency, positivity, and exchangeability.
There had been tons of interesting debates about masking and how to appropriately study it. And I think the one core thing that I think is important is you probably can't do a traditional confounding control study on masking just because the behavioral differences that lead some people to mask a lot versus some people to mask less are likely going to be almost impossible to pick up in any data set that we can get at. So you almost have to think about natural experiments or policy changes, or there were a few randomized trials of masking or mask policy that were done during the pandemic that you would point to as probably, again, the best evidence.
So then I guess the last one I wanted to just touch on would be the ability to triangulate evidence. So where you're trying to estimate the risk of not meeting an assumption, right? So in the case of one of my PhD students, there's a big risk. We're looking at the association between exposure to gestational diabetes and offspring risk for cardiovascular disease. And we're using an administrative data set. And the risk of unmeasured confounding is enormous in two areas, genetic susceptibility and then environmental exposure. So thinking about how could we tell the reader, right, or how could we estimate for ourselves, how much does this unmeasured confounding play into this association that a lot of people have shown? We would think about bringing in other designs. So it could be a natural experiment. Something I want to talk about later in season 2 would be bringing in negative exposures, negative controls, trying to estimate or trying to come up with elegant ways to find that unmeasured confounding and see, is it actually playing a role? So in the perinatal world, if you want to isolate it to an in utero exposure, you could take a look at fathers or aunts, right, the sister of the mother, and see whether or not that exposure has any association with some outcome in the offspring. And if it does, it's telling you that, hey, there's something else here. And then the composite of all that data allows you to make an inference about to what degree is that exposure causal, or are we getting signals from other places that we should be paying attention to? And a lot of people are leaning on Mendelian randomization as one tool to put in their triangulation toolbox, I guess.
I mean, I'm a big fan of what you just said, the triangulation toolbox, in terms of not relying on any single study design to answer any single question. And I think you can even throw randomized trials into that toolbox because, a randomized trial definitively answers a question about an exposure and an outcome, but it may be in a restricted population. It may be under, restricted and controlled conditions, like we were saying earlier, the extra treatments or the usual care may be relatively well controlled and the follow-up is well controlled. That might not generalize to the general population very well. So you'd like to know, okay, if I did a target trial, I'm not expecting necessarily the same answer, but I'm expecting a consistent answer from that target trial. And then if I go do a natural experiment, what answers would be consistent with that initial target trial approach? Initial trial. And do I see that? And then, you could even look at a ecological study, for example, I'm thinking of smoking and lung cancer. Well, we had the initial case control studies of smoking and lung cancer. Those were pretty strong evidence. You could look at just ecological studies of countries or areas with high smoking rates versus low smoking rates. You would expect those to show similar things to the case control. If they didn't show similar things, that would tell you at least maybe something is wrong with your confounding control in your case control designs. So you need to go back and rethink this. So it's not about the single study. It's about, do the set of studies all tell the same story? And there's another point in there with regard to triangulation. If you have 5 target trial emulations who all tell you the same story, a 6th target trial emulation study is with the same setup is not likely going to add much information there. A natural experiment or a Mendelian randomization study or something else, which is, essentially triangulating that initial result, is going to be much more informative to the question, is there actually something going on here, than that 6 target trial emulation study. So
Right.
it's all about thinking about the whole question and the whole answer, and how do you get at better versions of the whole question and the whole answer, rather than saying, okay, I'm going to lean only on this particular study design.
Right. We could have meta-analyzed observational data for hormone replacement therapy and cardiovascular disease, and every cohort study would have all shown, you could have 10 million women, and they would have all shown a protective effect. And then you do the randomized controlled trial or the target trial, and you realize, oh, wait a second. Under a different set of assumptions with different sources of bias, the answer is different. Now we should be thinking differently. My favorite example that we've used to teach this, Deb Lawler and George Davey-Smith and Cesar Victoria looked at the causal effects of breastfeeding on IQ, obesity, and blood pressure, where they took data from ALSPAC and then the Brazilian Pelotas study and a randomized controlled trial. And it throws off everything we think about breastfeeding, right? It's like by age 5, when you take the composite of all the data, there's no effect of breastfeeding on blood pressure, no effect on obesity, and modest effects on IQ. And what you see in one cohort study, like a famous cohort study like ALSPAC, can't be replicated in Brazil because it's a different population with a different set of confounding. And then when we take a look at a randomized controlled trial, which is a little harder, it's promotion of breastfeeding, it's not like actual breastfeeding. But again, that negative result combined with a negative result in Brazil calls into question the positive association you saw in the other cohort. So beautiful design, beautiful, thoughtful way of trying to address a really important question. So with that, anything we missed, anything else you wanted to talk about in terms of like transitioning yourself and your advisor into this area of causal inference that we missed?
I think the one thing the thing I would end with, and it's really a general statement about this, is all of these methods and all of these questions, all these methods, all of these designs, all of these thought processes are driven by the question first. And so where I would tell people to spend a lot of time at the beginning of any study is really, what is it that we want to know? And that may often come back to what is the action item or that we want to come out of this result. We often sort of don't think about that action item or decision that might come from the study. And, we're clear that if a regulator is deciding to approve a drug or not, they almost certainly need a well-done trial or multiple well-done trials that prove efficacy and show reasonable safety. In other settings, thinking about taking a drug off the market because of safety concerns, the question is different and the decision process is different. All that to say, thinking about really the question and driving your thought process by what is it we want to know and what are people going to do with this information, that might not lead you to the study design that you thought you needed to do at the beginning, but it should lead you to a better answer and more relevant information at the end. And it may lead you to the answer, what we got from this levothyroxine paper. We don't really know the answer, but it's better to have an imprecise answer to the right question than a precise answer to the wrong question.
Yeah, an imprecise answer with a really well done design than a more precise answer or a precise incorrect answer. Using a flawed design. And maybe the 2 to 3 hours you spend with your analyst, epidemiological expert, and your advisor beforehand could save you days of back and forth with a reviewer for your paper or back and forth with your analyst in the later stages of your project. It'll just save you a lot of time in the end. So that was awesome. Thank you so much for that. And we look forward to hopefully seeing you in Winnipeg at some point soon, back where you were born and raised, and then hopefully we see more residents coming up to you and others across Canada interested in applying these causal inference methods to their own research projects.
Thank you. Thanks again.
Thanks again. Really appreciate it. That was the second part of our conversation with Dr. Robert Platt, covering all aspects of causal epidemiology. Be sure to join us for episode 11 for the first in another 2-part series on qualitative methods with Dr. Maria Mayan from the University of Alberta. Thanks for listening. The Emerging Scholar Podcast was recorded in the UMFM studios located at the University of Manitoba in Winnipeg, Manitoba, Canada. This is Treaty 1 territory, the original homeland of the Anishinaabe, the Innu, and on the national homeland of the Red River Métis. Manitoba is also homeland to the Anishinaabe, the Dakota Iote, and the Dene peoples. We acknowledge that our water is sourced from Shoal Lake 40 First Nation. As a settler scientist working in health research, I acknowledge TRC call to action number 18, that health inequities between Indigenous and non-Indigenous people are the direct result of colonization. Winnipeg is the center for reconciliation in Canada, and where we are speaking from today is at the crossroads of Canada's history and Canada's future. We are 3 kilometers away from one of the most sacred meeting grounds for Indigenous people on the plains and within Turtle Island. We are also several kilometers away from one of the last residential schools in the province. We are working collectively on reconciliation with youth, elders, and community leaders to heal from the trauma of colonization, past and present, honor the original treaties, and create a Canada that addresses and eliminates the inequities and injustices of the past and present to create a future for Indigenous children to live and thrive. On behalf of the team at the Emerging Scholar podcast, we want to thank Osani Balkaran for the great production for our opening and closing themes. We also want to thank UMFM 101.5, especially co-producer Jared McKediak for technical assistance and production on this project. We also want to thank all of our guests for the discussion and the insight that they've provided. Once again, thank you for listening. Be sure to subscribe to the Emerging Scholar podcast on Apple Podcasts, Spotify, and umfm.com.